Welcome everyone. Let me invite you to immerse yourself in one of the greatest therapeutical challenges in the 21st century in pediatric care, which is in the era of exponentially expanding precision medicine. My topic is personalized pediatric oncological treatments for enhanced therapeutical effect and side effect minimization. I'm currently a third-year resident at the first Department of Pediatrics and conducting research at the Center for Translational Medicine at the second Department of Pediatrics. My vision is to give hope to pediatric oncological patients and their families by providing efficacious but less toxic therapeutic alternatives. And my mission is improving therapeutic success for pediatric oncology patients with personalized approaches. Our first step in this will be estimating additional targeted treatment efficacy. So, a brief overview of my topics. One is actually comparing the conventional and targeted therapies, and the second one will be focusing on a very hard to treat type of pediatric tumor that is currently untreatable. So, my first topic is the effectiveness of conventional and targeted therapies in pediatric oncology. Now, what do we mean by conventional? We mean chemotherapy, surgery, and radiotherapy. And why is this topic of the utmost importance? Every year, 400,000 pediatric patients are diagnosed around the globe. In the United States and Hungary is the leading cause of death by disease. And it places a very heavy burden on economy and healthcare, but most importantly, families worldwide. There are 40,000 patients that are currently under treatment at any given moment in the United States, and with the cost of $30,000, you can calculate that's $1.2 billion for those 40,000 patients for their whole course of treatment. What do we achieve by giving conventional therapies or current guidelines or protocols following current guidelines in pediatrics? We actually save 2/3 of the patients, but 1/3 still dies. Yet what price do we pay for this? 2/3 of the patients will still suffer from long-term side effects such as heart damage, lung damage, liver damage, cognitive impairment, and psychosocial reintegration problems. So you could ask, what is personalized or targeted therapy? We can have a cell retrained from the patient either by surgery, biopsy, direct biopsy or liquid biopsy, and analyze the genomic profile, search for alterations in driver genes which actually drive tumorigenesis. And based on that, we can find a molecule that targets that exact mutation and hunches down the tumorigenesis. If we introduce this therapy early on, we could improve survival, but not only that. We could give hope to the patients that we can reduce the side effects of conventional therapies. And my aim is establishing the therapeutical effect of additional targeted therapies compared to conventional treatment modalities in pediatric oncological patients. So our clinical question is, does this additional targeted therapy anyhow change the outcome of this disease? We believe that it is so. Our population is pediatric oncology patients that are given conventional therapy and targeted therapy, and we compare this population to those who only receive conventional therapy alone. We are focusing on the outcomes based on the RECIST response evaluation criteria: complete remission, partial remission, stable disease, or progressive disease, or in case death. And our hypothesis is that it will improve the quality of life of patients and the overall survival. And what is the clinical implication? We can establish guidelines that will likely have less side effects and be more therapeutically efficient. We conducted a systematic search in 5 databases and came up with 23,000 hits altogether. You can see that this is probably one of the longest search keys you've ever seen, and that is due to the complexity of the diseases, the different tumor names, and the vastness of the therapies that were tried out. And of course, we included the mode of genetic testing and the study type. So after going through these 23,000 titles, we are down to 10,000 in the selection, and by estimation we will have 80 to 90 eligible studies based on title and abstract. And my second topic is not least important. It's a very hard to treat tumor in pediatric patients. It's called diffuse intrinsic pontine glioma, or DIPG for short. And we are comparing the current treatments to find the best one to improve overall survival. DIPG is a very common malignancy in childhood with an overall survival of 10 months and a 99% 5-year mortality. It's a tumor that starts in the brainstem that affects breathing, heart rate, the way we walk and talk and eat. So you can imagine that it's surgically inapproachable and thus is very hard to treat. Not only that, but because we don't perform a surgery, the blood-brain barrier will remain intact and there's only a limited endogenous immune response towards DIPG. No therapies have proven curative thus far. The most promising therapies are epigenetic modifiers, transcriptional regulators, CAR-T immunotherapy, and microenvironmental targets. And our aim is to identify the best one and to establish a guideline based on it. So, are there any differences in the treatments? We believe so. And the patients population is patients with DIPG, and we're comparing all available treatment. Our response evaluation criteria is the same as in the first topic, and if we find one that is superior to other therapeutical options, we can establish a protocol or treatment guideline based on it. So to give you an overview of what I'm doing, I'm basically focusing on the most hard to treat diseases in pediatric age groups. And let's not forget that the real heroes are the warriors, the survivors, and those who have been taken by this disease that is sometimes incurable. And I'm devoting myself and I'm dedicating my research for that. And what is my purpose, you might ask? Your purpose in life is to find your purpose and give your whole heart and soul to it. And if you cannot find your purpose, if you can't figure out your purpose, figure out your passion, for your passion will lead you right into your purpose. And you might ask, what is my purpose? My passionate purpose is to give hope for the hopeless. Thank you for listening.
My question is for regarding the first project. You mentioned the population is pediatrics, oncology patients in general, and this is very broad for me. Like, are you planning to do subgroup analysis, because maybe pediatrics with or kids with different cancer maybe have different response rates?
Yes, thank you very much. This is an excellent question. You could see in the search key that we filtered down. Actually, I went through the WHO's tumor types. So I enlisted all of them in the search key that were to be found. So we are gathering all data and we are doing a subgroup analysis based on if they're hematological malignancy, if they're CNS tumors or non-CNS tumors. So these will be the three main subtypes. And of course, if we find enough data in each type of tumor, then we can do further subgroup analysis. But what will be most or even more interesting is that you can compare patients who had this genomic profiling done, and these medications were matched to their alterations, and you will find studies where they're focusing on certain biological agents regardless of matching, and we can also compare to those two and the outcomes of those.
And actually I have two questions, and the first is that in your first meta-analysis, will you do you have enough data to include those cases when they're used targeted therapy in the first-line treatment, or you can examine only the relapsed cases? And the second part of my question is that after these two meta-analyses, do you have any further plans regarding this topic.
Thank you very much. So for the first question, we found one currently existing meta-analysis that focused on comparing conventional therapies to targeted therapies, but not the two of them added together. And in clinical settings, it's unimaginable that you wouldn't cure a child with the most efficient or what is proved to be the most efficient therapy so far. So these targeted agents are only introduced when there is a relapse or if there's progression in the disease. And for your second question, we're planning on performing a registry analysis that is linked to the first topic of the National Cancer Childhood Registry, which is the longest established registry in Hungary. And we would like to merge the data from the genomic profiling and those children who received targeted treatments and describe their outcomes. And we would also like to perform clinical trials. We already have one in mind with DIPG, which is using a biological agent in genomic matched patients who have that exact driver gene alteration. And the other one is for hard to treat patients. We would like to see how different immunomodulatory therapies, or one especially how that works in these cases.
Are there any economic calculation in the literature about the cost benefit of this targeted therapy? Because we all know that they are really costly. They are really expensive, but if they are effective and if they can cure the patient, of course, for the long term, it's a big success. But however, are there any data regarding this field?
To my knowledge, to be honest, I didn't research that particular area of the literature, but my estimation would be that as we go along with the phase 1, 2, 3, so on trials with certain drugs, we will get to a level, if we see that they are feasible, good to use, they have better outcomes, they have less side effects, then it might be funded more, and maybe if they do a bigger production, the prices will also go down a bit. So cost effectiveness will be a question of the long-term use.